to the first episode of Bloodline Breakthroughs, Innovations and Inspiration. My name is Elissa Baldwin, Director of National Patient Education at the Leukemia and Lymphoma Society, and I will be your host today. We are excited to now offer a video podcast or vodcast and hope you will join us for future episodes where we discuss the latest advances in treatments for blood cancer, as well as hear inspirational stories from blood cancer patients and survivors. On today's episode, we will be speaking to Dr. Bilal Abid about CAR T-cell therapy. Dr. Abid is a clinical researcher in the Medical Oncology Department at the University of Texas Health Science Center at Houston. He has been the principal investigator on many clinical trials, and his research interests include CAR T-cell therapy, stem cell transplantation, adoptive T-cell transfer, cancer immunotherapies, and infectious diseases. Welcome, Dr. Abid.
Thank you for having me, Alyssa. Such a pleasure to be here.
So our episode today is on CAR T-cell therapy. Could you tell our listeners what that is?
CAR T-cell therapy is an engineered type of cancer treatment. So before I explain what CAR T-cell therapy is, it would be wise if we kind of go back how we have historically treated cancers. So either we chop the tumor off, do surgery, or wait and watch. There are certain tumors, certain cancers in which we can wait and observe them and continue to do surveillance. And then at a certain point in time, when they do progress or cause symptoms, then chop them off. Another way of treating cancers have been poison them, sort of use drugs such aka chemotherapy, which would poison them and kill those cancer cells. The third way of classical way of treating cancers is radiation. Give them really high doses of radioactive material, so that they burn. So now what happens is this is sort of a non-targeted, non-specific way of treating cancer, and hence what we call these treatments are accompanied by side effects, or more scientifically, adverse events. CAR T cell therapy, what it does is it's really orthogonal to Darwinian evolution. What is done is we take T cells from the patient itself, such as they remain self to the patient. And then when they are given back to the patient, they are identified as host's own. So there is no sort of, the immune system does not get revved up identifying something foreign. So patients are put on a machine, T cells are harvested, good T cells, select a sort of subset of T cells which are good and continue to maintain good function. And then you take them to the lab, engineer them in a way that you want to express a specific protein on the surface of T cell that targets the tumor cell in a very specific manner. So it's a gorgeous design. And then you kind of allow them, you grow them further. Once they have that specific protein called CAR is chimeric antigen receptor. So once they have that CAR protein on their surface, you grow them in the lab. And then once they are adequately grown and reach a certain number, and you feel you're ready to take them back to the patient, then you harvest a good mixture of cells, subset of those CAR T cells, which have those specific protein, take them back to the patient's bedside, give patients some specific type of chemotherapy, which is typically called lymphodepletion chemotherapy, right prior to giving them those CAR T cells. And the purpose of lymphodepletion chemotherapy is to clear out any residual tumor, any sort of bad cancer cells that might be in there, and make their body and bone marrow very conducive to receiving those healthy incoming CAR T cells, so they can come in, go in the body, proliferate, hunt down cancer cell, chase them down, and kill them in a very specific manner.
Okay. So, what blood cancers are eligible?
So far, um, they are approved in FDA approved and by other regulatory agencies around the world. They're approved in leukemia and lymphoma, non-Hodgkin lymphoma, different varieties of it. At least in three different varieties of it, um, including CLL, which is sort of an overlap between leukemia and lymphoma. And all of these leukemia and lymphoma CAR T cell target one protein called CD19, which is exclusively expressed on the surface uh, of leukemia and lymphoma cells. The third disease in which CAR T cells are approved by the FDA is multiple myeloma. There are two CAR T cell products which are approved. Both target the same antigen, which is expressed on cancerous myeloma cells, multiple myeloma cells, but they have differences in their constructs in the way they're made.
Okay. So, is there a reason why some cancers are eligible and other cancers are not? It seems like you can't do CAR T cell, or at least right now, on myeloid malignancies. Is that correct?
That is correct. So it has to boil down to reasons which are sort of indigenous to cancer itself. Some cancers, so there are cancer cells, and there's this surrounding environment that is created within that cancer bed, and that's called, the fancy name is tumor microenvironment. So tumor micro and that surrounding area within the cancer bed, including the cancer cells, is complex in certain cancers and not as complex to navigate in some other cancers. So in AML that you pointed out, acute myeloid leukemia, the tumor microenvironment is complex. The genetic heterogeneity, the mutational burden, the target antigen are just so heterogeneous that it's not easy to design a CAR T cell with one antigen targeting in some cancers, particularly in solid tumors.
Mm-hmm. Okay. So really we really need to make sure then that it has some target to look for, right? So it can distinguish the cancer cells from other cells, say B cells, or healthy B cells, right?
That is correct. So that is absolutely. That's, I mean, that's really that's the purpose and the premise of designing CAR T cells, to be able to tell apart a healthy B cell versus a cancerous B cell. For example, BCMA, which is the target protein in multiple myeloma, is almost exclusively expressed in cancerous plasma cells.
Oh.
Obviously, there's certain some degree of collateral damage because BCMA is also expressed in some of the other very late precursors of B cells.
Mm-hmm.
But that collateral damage is sort of much lesser. Although it's there, it's much lesser than one would expect with non-specific cancer treatments such as chemotherapy and so on.
Are there any other considerations like age or other comorbidities that would make a patient not eligible for CAR T cell therapy?
It's in general, that's a great question. In general, it's a good therapy for patients who are conventionally unfit for, let's say, transplant, a bone marrow transplant.
Okay.
It's sort of more inclusive from an aerial perspective, but and age certainly is not an issue. It's folks who are even as old as in their late 70s, but they continue to maintain robust performance status and have limited comorbidity burden are certainly eligible for CAR T cell therapy. And we have studies now showing that in an elderly cohort, the outcomes are actually pretty comparable to their younger counterparts. Now, when it comes to comorbidity, overall comorbidity burden obviously matters. If somebody has a lot of different organ systems diseased going into CAR T cell, then the overall outlook will not be as good. And so there are some other comorbidities indigenously. For example, somebody has pre-existing pretty significant heart failure, ejection fraction is considerably low. Then there are certain immune related events that happen after CAR T cell infusion that that specific patient will not be able to withstand. So it's a very personalized sort of an approach, but I would just say that CAR T cell allows more patients to undergo this treatment in a relapsed refractory setting than one would imagine with, let's say, transplantation.
Okay, that's good. So, how is CAR T different from other treatments? What makes this a really exciting treatment option for some patients?
It's exciting because we we see that first of all, CAR Ts are, let's say in myeloma, both CAR Ts were first approved in the fourth line setting, which means they have already received four different lines and four different regimens, distinctive regimens of treatment previously, and their disease remained progressive. So this is so CAR T is for patients who have not had good treatment options historically. So CAR T provides an additional and very exciting and efficacious treatment options for those patients who have limited options otherwise. And to be very frank, in our clinical practice, let's say if we go back 2 3 years ago, we would send those patients to best supportive care or to hospice, at least a fraction of them. And then a fraction of those patients now become eligible for further treatment. And a good proportion of these patients, end up maintaining long-term remissions, long-term durable remissions. So there's a lot of excitement about CAR T cell therapy in general.
That is wonderful. So, I'm sure a lot of patients who are looking into CAR T cell therapy really want to know, is this covered by insurance?
So that's a great question. Initially, there had been issues, but since it's FDA approved, it has NCCN label um, in all three hematologic disorders that we talked about earlier. Um, really, insurance reimbursements are not an issue any longer. If the treating physician or the team of cell therapists at any academic center decide that this patient is a candidate for this specific type of CAR T cell product, then insurance reimbursements are fairly universal.
Okay. So let's dig back into the process of CAR T cell therapy. So you had said that the T cells are removed from the patient, and then there's some time it takes to modify these T cells. So, what is that waiting period like for patients? Because it's a few weeks in there. So, between the time they take the cells until they get it put back in, I would think that that might be a little stressful. Are there additional side effects that may come on, or the disease progressing during that time?
That's a very relevant question, I must say. So certainly there are. So first of all, I think that the first part of your question was how long does it take? So that differs from product to product. But the typical, let's say, if you were to take a ballpark, it takes anywhere between 3 to 6 weeks for cell manufacturing. So from harvest to infusion, it's about anywhere between 3 to 6 weeks. Now during that time, obviously there's a risk of disease progression. Then comes in other. Obviously there are ways to temporize the disease and control the disease. And that's done through chemotherapy regimens or radiation or through some newer agents called bispecific antibodies. So there are ways to control the disease from progressing in that interim, the time that takes between cell harvest and cell manufacturing and return.
So I'm sure that patients are really happy to hear this because I would think that, if they're looking at several weeks without treatment and the disease progresses, they know there's something there that can help manage their disease and keep them going until they can get that CAR T cell infusion. So that's really good to know. Now, what happens after the procedure where the modified T cells are put back into the patient? Are they immunocompromised? Do the patients have similar restrictions put on them like they would with a stem cell transplant?
The short answer is yes, they are immunocompromised. A little more nuanced answer would be that in the very early phase, these patients are typically in the hospital. The first few days, they're monitored pretty closely for some immune mediated changes that can occur in their bodies after CAR T cell infusion. As T cells come in, they're revved up, they proliferate, they release certain chemicals called interleukins and stuff, and that can lead to fevers, blood pressure drops, heart rate elevation, and all of this hodgepodge put together is scientifically called cytokine release syndrome, which is a very
Oh,
well known and well identified early complication of CAR T cell. Typically occurs between day 3 and day 15. The other very well known early complication is neurotoxicity. CAR T cells can cause mental neurologic changes, and that has to be monitored closely after CAR T cell infusion. Now, luckily, over the last few years, cell therapists and all of us at the academic centers, we have learned how to manage these over the course, and even to how to even prevent them. So they don't happen as much
oh,
as really. I mean, when I remember when the first CAR was approved, and when they were in clinical trials 4 or 5 years ago, the cytokine release syndrome rates were pretty high, and even the higher grade, more severe cytokine release syndrome and neurologic toxicities were actually used to be, sort of more patients would experience them than less. And now it's the other way around. So I do think we've come a long way as a field. Now, the second part of your question, are they immunocompromised? The short answer is yes, they are. Now, how different is their immunocompromised state is as compared to, let's say, folks who undergo allogeneic transplantation, bone marrow transplantation, which means they get their donor from someone else and not their own cells. Um,
mhm.
they could be considered less immunosuppressed than those patients. However, they are immunosuppressed. So they do need to get on a vaccination schedule, 6 months beyond, starting 6 months beyond CAR T cells. There are very specific guidelines out there which can be referred to. And I encourage patients and their family members to consult their cell therapist who would follow these guidelines for them. One point to remember, Ms. Baldwin, would be that the farther out patients get from CAR T cell infusion and continue to maintain remission from their underlying disease, the lesser immunocompromised they continue to become. So
Oh, okay.
that's just the science behind CAR T cell that must be remembered.
Okay. So you mentioned a couple side effects and said that they could be managed or even prevented. How is that?
So over the course we all did studies at our centers, and there were some central registry based analyses There have been early phase clinical trials that have been conducted of using different agents to prevent um, cytokine release syndrome. For example, those early fevers and blood pressure changes. So, and then steroids have been used to prevent. So, multiple strategies, multiple drugs, closer monitoring, preempting them based on disease burden, before going into CAR T cell, patient characteristics, the type of CAR T cell that they'll be receiving. So all of that put together sort of give out a personalized picture for any given patient to predict the risk of those early immune mediated toxicities, and hence allow a sort of a more personalized preventive strategy to be put into place.
Okay, that's good to know. Now, are there long term side effects or late side effects that could come up?
There are. So infections continue to be with continue to sort of unfortunately stick with patients who have received CAR T cell infusion. So masking, avoiding public gathering, and some of these general guidelines continue to apply to them for considerable amount of time beyond CAR T cell infusion. But I mean, some delayed and more prolonged adverse events with CAR T cell infusion include their blood counts will remain low for a certain period of time. They may come up at 4 months or 5 month mark or 6 month mark, or might even take slightly longer. But eventually they have their blood counts return to normal. If the CAR T cell continue to work within their body, continue to survive and grow within their bodies. The other thing is that CAR T cell lead to what we call B cell aplasia, which simply mean it depletes their B cells of the immune system. It takes them out, and B cells are important in generating antibodies. So what happens is, and antibodies are important in preventing certain type of self-infections. So it's important to kind of keep an eye on their antibody status in the body and replete them. Give them immunoglobulin antibody infusions from time to time. Monthly is the recommendation, but this is another way of doing things. So infection, blood counts remaining low, and the third one is uh, low antibody and immunoglobulin levels.
So, where are we going with CAR T cell therapy in the future? Could CAR T cell therapy be a potential cure for some cancers?
Cure is, see, that's a great question again. Cure is a word that's hard to use with blood cancers in general, right? For example, multiple myeloma overall survival um, in the 80s was under 2 years. Now is in excess of 13, 14 years. Median overall survival for standard risk multiple myeloma. Have we cured multiple myeloma? Probably no. I mean, we can put these patients into durable remissions because of availability of several highly effective treatments. So, cure is a difficult word to use, but when it comes to CAR T cell therapy, uh, CAR T cell therapy certainly has put patients into durable remissions. Um, we do need. Can we say this about all CAR T cell products? Can we say this about all types of blood disorders? Not as yet, but in at least in large B cell lymphoma and in ALL, patients who are put into remission early, at least a fraction of patients end up going to achieve long term and durable remissions.
That is very good to know. Now, for future research with CAR T, are we looking at a potential for off the shelf products or looking at a potential to use it on other blood cancers?
Absolutely. So, I mean, because it has really worked in some types of blood cancers very well. It needs to move to other blood cancer types as well. So, so one, I think one of your question is whether it should be used. Absolutely, yes. There's considerable investigation in AML. There's significant investigation in other types of lymphoma. There are investigations ongoing in other plasma cell dyscrasias other than multiple myeloma. Um, we saw not long ago, just a few months ago, a car product, CD19 car product, getting approved in CLL as well, so which is very exciting. So certainly it is
Okay.
going significant on investigation at this point as we talk.
So you've brought up a few times now about CAR T cell products and different products. Could you explain to our viewers what different products are and what that really means?
That's a great question. CAR T cell products are called products or constructs because they differ in their design, in their safety, in their efficacy. So, having more than one product for each disease allows selecting the optimal product or drug for the right patient. So, it just allows, it's just a beautiful thing to have for our patients. For example, in myeloma, we have two CAR T cell products, both targeting the same tumor protein, but they are different in their design, in their efficacy. One of them could lead to longer sort of progression-free survival than the other, while the other one may have, different toxicity or safety profile, tolerability profile. Similarly, we have four products. In myeloma, we have ide-cel or Abecma and cilta-cel or Carvykti. Similarly, in the other B cell hematologic malignancies, including B cell ALL, CLL, SLL, and histologies of large B cell lymphoma, we have four CD19 targeting CAR T cell products. We have Axicell or Yescarta, we have Tisacell or Kymriah, we have Lisacell or Breyanzi, and then we have Tecartus. So we are so basically they all target the same antigen, but they differ in their efficacy, safety, tolerability, and that allows sort of personalization of CAR T cell choices based on patient's profile, based on disease profile.
Okay, so really another way to get that really targeted, individualized treatment then.
That's correct. That is absolutely correct. It really allows that individualization according to patient profile.
Okay, that's great to know. So, our final question today, this program is titled Bloodline Breakthroughs Innovations and Inspiration. How do you envision the breakthroughs we talked about today changing patient outcomes?
Alyssa, we live in a very exciting time, and I see it as a real exciting time in the field of hematologic malignancies, and then really in oncology at large. We have CAR T cell products already FDA approved for multiple indications in hematologic malignancies. Now, really moving on towards other more complex heme malignancies, more importantly, moving on towards solid tumors, which actually account for a large majority of overall cancer burden nationally and globally. We have bispecific antibodies, which are universally available, off the shelf product. They don't need to be personally engineered. They're there when the patient needs them, and they're already approved not just in hematologic malignancy setting, in myeloma and lymphoma settings. We now have bispecific antibodies approved in small cell and non-small cell lung cancer setting. We have autologous TCR T cell receptors, which are sort of different from CAR T cells, but they fall under the umbrella of engineered T cell therapies. We have those, and then we have tumor infiltrating lymphocytes approved in in metastatic melanoma setting and sarcoma setting. So we live in a very exciting time, and uh, I can only I can only be nothing but excited about all the therapies that we have incoming and those that are in therapeutic pipeline. Just as we talk.
Absolutely. It really is an exciting time, and particularly over the last few years with so much blood cancer research being done, and so many more options available for patients. Just like you talked about, even within CAR T cell therapy, there's so many different options available, and that is just so exciting. But thank you so much, Dr. Abid, for being our very first guest for Bloodline Breakthroughs, Innovations, and Inspiration. We really appreciate you telling us all about CAR T cell therapy today. And we, again, really, really appreciate you being here.
Well, it was a great pleasure having being on with you, and thank you for having me.
Yes, thank you. And thank you to everyone tuning into our first episode of Bloodline Breakthroughs, Innovations, and Inspiration. Be sure to visit the link below for more information about our topic today, and we look forward to seeing you next time.